Okay.
Hello?
The
Hello?
question is for?
The question is for the whole team. My name is Jan, and I'm suffering from autism myself, and I'm in the board of the Autism Europe. And what is written there, but it is all for the other ones. Psychosis was approximately present 3 times as often, and so on. My question is, I think that certainly depression, I know, anxiety disorder, and OCD has to do with development and social problems. But also, my question is if you can say that psychosis is present 3 times as often than normal, if that is not the result of the educational history and life history and social problems, because psychiatrists want to say that in a mysterious way something with the neurotransmitters arise and it is dopamine, but I think that I read it as a result of the very severe social problems of autistic people, then that they become these psychiatric problems. But what are you thinking about?
Can I answer that? Yeah. Is this working? No. Let's try another one. This is one of my favorite topics, so I thank you for the question. It's one. I do research in psychosis, so I think that mystery is very to the point of what we know right now, because there's no simple explanation of why some people develop psychotic disorders, but I think it's a mixture of many things. And as I have seen in my, the most common explanation is that development of psychosis is a mixture of inheritance and environmental factors, as you say, the social milieu. But what I have experienced from my clinical practice, because I treat people with those conditions, is that people with Asperger's syndrome or high function autism, when they exit high school, they become very isolated, and they previously idiosyncratic ideas or way of living get more and more extreme, and they develop something I call pseudo-psychosis, which is not really schizophrenia, but is as you say, a result of living extremely isolated and having no impulses from outside. Many of these in Norway, many of these young men, they live in their child room until they are 46, and they have not friends, and their parents are exhausted, and so on. So you might say that in this group there might be a lot of psychosis with somewhat different origin that in the normal population. That's what I think. It's hard to say something very bombastic on that, but what we think is that if these people if they have more, if they participate in society in more ordinary ways, some of these psychoses might be prevented, but not all, because we see that also that some people with autism develop more classic schizophrenia, and they will be psychotic anyhow, in any way. So there are basically 2 different psychotic disorders.
I'd like to say a little more about what we see is sometimes, especially in high-functioning individuals, we think they are psychotic, but it's just a misunderstanding of social signals. Like a young man I saw, and he had a postcard, and the postcard said, "Your age is going to get you," and he didn't leave the house for a month because he thought someone was going to get him. And in these cases, I think we can help by helping them interpret social situations and communication, and that can prevent a lot of anxiety and harm. So
I think basically it's the same thing we are saying in different ways. Yes.
Can I add to that as well? That a lot of cases that we saw, it was related to, it was very difficult to actually differentiate individuals that had difficulties with social interpretation or social interactions. And so we saw a lot of individuals where you could ask particular questions to assess for the presence of psychosis, but you had to go a little bit further to make sure that it wasn't related to social misunderstanding. So one of the most common things that we would ask when we're looking at the assessment of the presence of psychosis is whether people respond to things that other people may not be able to see, or one of the common things that we had the parents of people with autism report was that in fact they spent a lot of time talking to themselves and talking alone. So the parents interpreted that as the young person responding to something that wasn't there. But when the person was seen on their own, in fact it was them trying to understand and interpret and play a particular social interaction that had occurred in the past. So it was them trying to understand that.
Okay, I was just going to comment, not another question. I'm a Swedish adult psychiatrist working with adults with autism spectrum disorders and also with schizophrenia for many years. And I would like to point out that there are other authors pointing to the high prevalence of psychosis and especially schizophrenia in large materials of people with autism spectrum disorders or intellectual disability. For example, from Australia, Vera Morgan and Jablensky have pointed this out. Also, I would like just to comment on these matters, that I think a nice way of putting it and a nice way of viewing it is that developmental disorders make you more vulnerable for all kinds of psychiatric disorders. Thank you.
That makes it very interesting. If we know how the genes are related to these disorders, it's interesting to know which disorders are there then at that time. So, not clear what I said. Okay.
Psychiatric disorders overlap.
Yes.
As Lena pointed out, there are no what you call unique markers for different disorders in psychiatry. It's only in the books that the disorder neatly differ from each other. In real people, we know that all people with psychiatric problems have some level of anxiety, for example, and anxiety is maybe the most prevalent disorder in people with autism. So we have to think very complex when we deal with these disorders in people with autism, as we do in the general population. And I think that this is maybe the most interesting finding the last years, that people with autism, they suffer from the same psychiatric disorders as all people do, and they have to be treated the same way, but corrugated for their impairments. So it's all we have to think very complex.
Ci sono altre domande? Any more questions?
Scusate se la faccio in italiano, però è complesso in inglese. Allora, noi lavoriamo con un gruppo di adolescenti, sono tutti da 16 anni in su, con disabilità intellettiva molto grave, e i disturbi psichiatrici rispetto alla sintomatologia sembrano molto evidenti. Abbiamo visto che in alcuni di questi soggetti, che presentano anche un quadro epilettico, c'è una resistenza forte al farmaco antiepilettico. Invece sembra esserci una buona risposta alla farmacologia che va a ridurre l'ansia. Quindi sicuramente il disturbo, quello di tipo ansiolitico, è il più comune. E in alcuni casi, ma stiamo parlando di un consistente numero di casi, cioè 15 persone su un gruppo, insomma, più o meno di 30 persone epilettiche, quindi la metà, il farmaco per la riduzione dell'ansia riduce la frequenza e l'intensità delle crisi epilettiche. Volevo sapere se c'erano degli studi in questa direzione e qual è il livello di disabilità cognitiva al di sopra o al di sotto della quale è possibile fare una valutazione di tipo psichiatrico. Grazie.
Probably not the right person to answer that question. I've missed the start of your question, actually. So are you asking about particular studies that are looking at how individuals with autism respond to anti-epileptic medication in comparison to anxiolytic medications? Is that right?
Sì, e anche se magari questo invece l'avete potuto osservare, il livello di disabilità cognitiva, anche, dicevo, questo magari avete potuto osservarlo direttamente, qual è il livello di disabilità cognitiva al di sotto, al di sopra delle quali è possibile fare una valutazione di tipo psichiatrico.
Oh, and the other question was whether we saw individuals below a level of intellectual disability or intellectual functioning where we can actually assess the presence of psychiatric disorders. Was that right? Yeah. So I don't think I can answer the first question because the first one?
Yeah, no. There are no
medical panel,
doctors here on the board, so we are not. We don't feel well about answering that question.
Yeah.
And medication in ASD is a topic tomorrow morning. I think in the Blue Room. So I think there are a lot of doctors there that can answer that better than us.
Yeah.
And to the second question. Yes, in our study we found that it is possible to identify psychiatric problems even in people with profound intellectual disability and autism, and that is also what we see in clinical practice. And then we have to use the behavioral equivalents to the, in fact, DSM criteria. So that is, and she's nodding here.
I can agree with that. The young people that we did see ranged from, like I said, to high functioning to having a severe intellectual disability. Now, it's very difficult to diagnose autism in young people with profound intellectual disability, so our sample didn't actually have any individuals with profound ID, but there were certainly individuals with severe intellectual disability, and it was well and truly possible to diagnose psychiatric disorders in them. But obviously we had to rely on behavioural markers of that disorder and reports from the parents and the carers.
And I can add to that it is, of course, much easier to identify psychiatric problems as the person grows older, because then the behavioral patterns become more stable over time and the personality sets in a way. So as we see it in the adolescent people with intellectual disability and autism, it's a lot more difficult to assess the psychiatric problems than when they, for example, become 25, 30 years old and the personality is more set.